Yeah, good morning. So I'm going to just take a nanosecond before we begin, and as you're taking your seats, to thank Ashley Ray, who's a member of our team, who really was the person who saw through the agenda while all of the rest of us were telling her what to do, and instead she was guiding us wonderfully. So I wanted to thank Ashley, who's standing right there. And Tracy Rutnick and Rachel Pulley are the people who are keeping you moving into the right places at the right time, registered. And also want to just say thank you to Marion of the Woodmark Group. She was fearless, and I can imagine it being pretty anxiety-producing to do this. And so gratitude to Marion as well. Now, our goals for today are really to see how we can put the principles that we started off with, the principles of a child first or children first agenda, and see how we can put those into action. And so we're going to be starting with a kind of a rapid fire series of efforts on the community level to put those kinds of principles into practice. And then we will move to an example of a social enterprise which tries to achieve that job. You've been hearing a lot from nonprofits and even a PAC, and this is an example of a social enterprise. And when we break up for table talks among you, we're going to ask you to kind of consolidate around tables if there are any small ones and not too full. But we're going to ask you basically 3 questions. Are these principles that you found on your chair when you first arrived, are these principles behind which you can stand? Do they, as succinct as they are, do they reflect your commitment to putting kids first? So that's question number 1. Question number 2 relates to where you fit on that continuum of culture change, which is really the goal, to change the way we think about kids, or to move the kids front and center to our thinking. So where do you fit on that continuum of change? The philanthropists in the room have been agents of change all along and continue to be. That's one way. Others who, or even the same people who also in their professional life as executives or as directors or as trustees of nonprofits, how do you use that? How do you bring that children first commitment to that work? And then finally, as citizens where you have an opportunity to educate others as part of our democracy and to educate policymakers as well. So how do you think about where you're situated on that continuum of change? And so that's what we'll be talking about during Table Talks. And then we'll end with a conversation amongst Katie Taylor, Ted Gerard, and Dave Alexander to talk a little bit about next steps and get your thoughts about what those should look like. But this morning what we're going to start out with is some pretty inspiring stories, examples of efforts to put kids first on a community level. These are sort of outstanding examples of ongoing programs. And we're going to start with examples from Cincinnati, Ohio, and from Columbus, Ohio. And they're going to talk about a project they've been doing. Their model is measured by a pure kind of population-based metrics, and it'll be interesting to hear. So we're going to hear from Dr. Rob Kahn. He is a professor of pediatrics and associate chair for community health at Cincinnati Children's Hospital in Columbus. And then we're going to hear from Steve Allen, who's CEO of Nationwide Children's Hospital in Columbus. So join me in welcoming them both. Sorry, I left water behind.
Thank you very much, and I think we have a few slides we'll be sharing as well. So thank you very much for having us. Children's hospitals have always been very committed and passionate to the care of kids who walk through their doors. And what Steve and I want to share a little bit about is how both our children's hospitals are trying to bring equal commitment and passion to children and families who may not come through our doors, and specifically focus on place-based strategies or neighborhood-based strategies in which the denominator is the number of kids living in a neighborhood, as an essential set of strategies to ensuring that all children thrive. So in the next 10 minutes of lightning talking, we're going to describe persistent child health inequities and some of the root causes. We'll talk about place-based metrics, strategies, and results. We'll discuss why now, and why children's hospitals are positioned to catalyze this work, and offer next steps in how we can go forward in creating a movement of children's hospitals to ensure kids thrive. Well, what do we mean by child health inequities and root causes? What you're looking at here is 3 years' worth of asthma admissions to our county, Hamilton County, where Cincinnati sits. And across the bottom are the 85 or so neighborhoods of our county. And the height of the bars reflects the rate of admissions per 1,000 children. And what you can quickly note are two things. First is the tremendous gradient or inequity in the rate of admissions across the county, right? So the kids to your left have 15-fold increased rates of admission than the rates to the kids on the right. And the second notable thing is that off to the right, there are 3 or 4 neighborhoods without a single admission for asthma across those 3 years. So with existing genomics, with existing medications, these neighborhoods and the families in those neighborhoods have figured out how to keep their kids out of the hospital. So what's going on that's different between the two neighborhoods? In those high-rate neighborhoods, it's toxic housing, it's low medication adherence, it's increased air pollution, and it's high rates of poverty. In both the neighborhoods that Columbus and Cincinnati are focusing on for our deepest dives, there's child poverty rates of 60%. So the question really then is it just around asthma? No. Here's the asthma rate. Here's unintentional injury for kids. Here's the preterm birth rate. And here's third-grade reading scores for kids across the Cincinnati public schools. And the same neighborhoods show up as at high risk for no matter what the condition is, suggesting that there are common root causes to all this excess morbidity. And as is frequently stated in our world, that the zip code is equally important, if not more important, than genetic code for certain conditions and certain populations. And what we're trying to really hard to do is figure out what's the right role for children's hospitals in addressing some of these broader determinants. So how are Cincinnati and Columbus approaching this? We're trying to build a system or a network of caring driven by both science and passion. And these are sort of 6 of the main elements, though there's more to be discovered, I'm sure, from the work everybody's doing in their own cities. So first and foremost, engaging families from the neighborhoods to help set the vision and solve problems. And I think in both places, we're listening a lot better to those families to learn about their own resilience and strengths and how to organize those strengths to drive the work. We're thinking about metrics that focus on the health of all children with built-in equity indicators to make sure we're driving towards some of those root causes. We're engaging multiple sectors like education and housing and job training in a shared vision and a shared set of strategies for getting better. We're being very attentive to disciplined learning or the science of improvement. So we've learned from industry essentially how to try to get better every single day, whether it's safety errors or ventilator-associated pneumonia, and applying that to the same community work. We're relying heavily on philanthropy that lets us take risks and learn as quickly as we can while holding us responsible to outcomes. And finally, we're hoping to create a movement. We're learning as fast as we can from each other, but as we say, sharing seamlessly and stealing shamelessly. And we're anticipating a conference at the end of August where we're hoping 8 to 10 cities and children's hospitals will be coming to learn some of our shared approaches. So no single strategy by itself is unique or extraordinary, but I think what we're finding is the collective execution of all of them together are producing some extraordinary early results that we'll both be sharing. So specifically in Cincinnati, what's happening, the board has endorsed helping Cincinnati's 66,000 kids be the healthiest in the nation through strong partnerships, and the partnerships piece was very important to moving forward. We have 2 sets of metrics, 2 around morbidity and mortality, 2 around thriving, and specifically it's around reducing annual infant deaths for the county, reducing the disparity in hospital admissions and bed days. And then in the thriving space, right, it's not enough that babies don't die or the kids aren't in the hospital. It's ensuring 5-year-olds have a healthy mind and body as they enter kindergarten. And you can see some of the pieces of that bundle measure that Dr. Redlener highlighted yesterday. And supporting the Cincinnati public schools and ensuring that children are reading proficiently or above by 3rd grade. So I'm just going to share 2 sets of results in the interest of time. So extreme prematurity is the #1 driver of infant mortality. high rates of mortality for babies born less than 28 weeks, and lifelong disability if they survive. And what we've tried to do in this work is bring those same 6 principles that I just mentioned to the effort. So here's some results from Avondale, one of those neighborhoods I highlighted earlier. And what you're looking at here is every quarter, essentially, on average, 1 extreme preterm birth occurs in Avondale, a very low-income neighborhood. We organized to drive some of those design strategies I just talked about: obstetricians, home visitors, legal aid, and others coming together, community health workers. And what we've seen over the last 10 quarters, after we spent a year or so organizing, is not a single extreme preterm birth. That's 10 babies that were not born too early. Now, you could say, well, is that demographic trends or gentrification? Here's a set of comparison neighborhoods that surround Avondale, demonstrating there is no background improvement in the rates of extreme preterm birth. I'll give you one other example around hospital admissions. Every day one of these children spend a day in the hospital is a day they're not in school learning, and a day their parent at a low-wage job is not earning critical income. What you see here for Avondale is the bed days per 1,000 children. You see at a baseline we had about 109 bed days per 1,000 children. In fiscal year 17, we just finished at about 95 bed days, or a 13% reduction, or 23 additional days of kids in the school in the local Avondale schools. Again, is there a background trend? Was it a low flu season or a low asthma season? No. You see again in the surrounding neighborhoods, there was no change. So we have a tremendous amount still to learn, but these effects are rippling through the public schools. United Way, the mayor, are all growing an interest in this work. And I'd be excited, we are excited to share the findings in an ongoing way. I'm going to turn it over to Steve, and he'll share some of the incredible work happening in Columbus.
Well, I hope that gives you some sense of some of the great work that can go on. I'm going to show you a little bit of the results that comes from Columbus, but I think what I would want to make sure that the audience leaves with is that there's fabulous academic medical centers in the room and have done great work. And physicians of my generation were raised on the idea that the best academic medical centers stood on a 3-legged stool. We took outstanding clinical care of patients, we trained the next generation of providers, and we generated new knowledge through research. But I would propose that we need to consider a 4th leg to that, and that's that we advocate on behalf of all the children in our community. So there's a compelling drive to the mission when you take care of children that just goes above and beyond what, in my previous life in an adult academic medical center, that we would consider. And the role that these kind of anchor institutions can play as either a convener or a catalyst or a motivator and setting forth the challenge just, I think, is so powerful in our communities. We have our initiative in Columbus is to take a 5-pronged approach to go outside the 4 walls of our institutions, much as my colleague from Cincinnati described. It's education, rebuilding the neighborhoods, obviously health and wellness for this population of children, affordable housing, and workforce development. I'm not going to talk a lot about workforce. I have a little bit about workforce development. The reason why that's important to us is not because we're trying to hire our patients, but we have found that their health care, as you probably heard at various times of the past couple of days, if their child's health care is related to their parents' ability to have meaningful work. So we feel that if we're going to advocate for children, then we need to figure out a way to get their parents employed. We've had an initiative now over 7 years where we have gone and reduced the number of vacant and dilapidated housing in the 3 zip codes that surround the hospital, which is very similar to many other blighted inner-city urban neighborhoods. About half of those homes we took down to the foundation and just rebuilt it up and then financed it back at below market rates. That project now has spent about $31 million over the 7 years. $6 million was children's, but because of the way that the rest of the community responded to this as being a way to really help elevate the community, we were able to get a lot of other partners to come in and leverage our investment. We are delighted that we were also able to get a public-private partnership to build a $10 million low housing income tax credit facility. This will have 58 affordable housing units. It's in our neighborhood, but at the core of it is a workforce developing facility which we will staff. And again, that we are doing the workforce development, but we were able to get so many other community partners to step up and say, okay, we're going to help you build this thing and underwrite it. Similar to what Rob was talking about, we've had initiatives to try to decrease the number of asthma readmissions. I think one of the things that's often in the elephant in the room is that when we do these things to improve health, as the CEO of a hospital, I can tell you this hits revenue. So there's this conflict often in American healthcare leaders' minds about how is it that we pursue this in ways that we can still make ourselves financially whole. We have some initiatives as a Cincinnati, which we're not going to cover with today, to try to deal with that, but I think it's an important concept to get across. Similar to Cincinnati, we've had an initiative to decrease the number of premature infants. In my system, neonatal beds make up 40% of our inpatient beds, but those families would be so much better if those babies just stayed in a little bit longer. Through teen pregnancy, what we've had is an initial efforts to try to improve access to long-acting reversible contraception for adolescents. I'm out of time, so I'm going to drop off the PACS behavior and just reemphasize some of the points I want to make. There's a lot of good things that can be done. You've seen a lot of data from some projects that we've had, but the thing I want to leave you with again is the fact that children's hospitals are uniquely positioned to be the advocates to motivate and inspire a community to try to raise even the most disenfranchised children out of their poverty and improve their ability to achieve full potential. With that, thank you for letting us talk to you.
Thank you so much. We're now going to turn, because we're running a little behind in time, so we're going to now turn to Greg Barrett and Clifford Rao. Am I supposed to move? Okay, I will move. And what they're going to do is talk about their work in Western Pennsylvania. And so Greg Barrett is President and Chief Development Officer of Children's Hospital of Pittsburgh Foundation. And Clifford Rao is Chair of the Children's Hospital of Pittsburgh Foundation. And so we'll hear from you both.
Okay, thank you. I never like standing behind a podium. Does this thing work? I get nervous standing behind a podium. Thank you. So we're going to take a little different tack. First of all, I want to thank the previous presenters. That is really exciting work, and we want to learn more about it. We're doing a lot of very similar things today. What we thought we would talk about with this is less about what our hospital is doing and a little bit more about what we're going to try to do to kind of carry this message of bringing an agenda of bringing children first. So for us, our journey with this actually started about 4 years ago. We started planning for our 125th anniversary celebration. So June 4, 1890 was the date that we admitted the first child to our hospital. And we were planning a year-long process of celebration for that. And we were going to do what I would assume a lot of people would do. We were going to celebrate all the great achievements of our hospital, Jonas Salk and the founding of the polio vaccine, Tom Starzl and transplantation surgery, and talk about our kids and their heroism. And we were putting together plans around this. And what came up that was sort of interesting to me is one of my staff brought the original documents of incorporation from actually 1889 to me and let me look at those. And what I thought was really interesting is there were a lot of names that for Pittsburghers we know today, and probably some of you will even know these, recognized names like Mellon or Frick or Carnegie. Some of you might have heard of these names. And those were the people that were on our original board of incorporators. And I sort of was thinking about that a little bit, and then I read the original mission that they had drafted, which said that Children's Hospital of Pittsburgh would be available to every child in the region, regardless of race, in 1890, religion, and this was in a time when, dogs and Catholics, please use the back door, or ability to pay. And I just thought that was a really, and I'm sure most of us, if not all of our hospitals, have a similar founding story. And I thought about that a lot. I don't know why. And all of a sudden, to me, I heard something that sort of struck me, which is, if Henry Clay Frick's child, actually Henry Clay Frick's child did get very sick, and one of his children ended up dying. But when his child got sick, I'm confident that that child didn't go to the children's hospital. I'm fairly confident that that child went to, or the doctor went to Henry Clay Frick's mansion and cared for that child there, because really with the technology at the time and what was ailing that child, probably the best thing they could hope for is that that child had a clean, bright place to heal, and that's what they could provide in their home. And what, though, by putting together this hospital, all of those people that were the original incorporators were saying to me 125 years later is that they believed, they knew that not every child in Pittsburgh did have that. You know, Pittsburgh then was, as Mark Twain said, hell with the lid off, right? And I think that they understood that not every child had what they had. And what they were telling me is that they built that hospital because they believed that every child in that region was their child. And we changed our plans for how we were going to celebrate our 125th and moved away from how great the hospital was, and we focused on the covenant that the people of Pittsburgh had made over the past 125 years to continue that legacy that those Board of Incorporators made, that they believed that every child was their child. And everybody, all of our board members, our donors, continued that. And when I'm here and we talk about a Children's First agenda, and I look out in this room, every one of you has made that commitment, and you are saying every child is your child. And I think that is a tremendous commitment. And when we talked about what we want to do in terms, even before this conference, we realized that we want to find a way to mobilize our community and really get them thinking about that. So we began a year of celebrations around our community and that commitment. And today, what we're going to be doing is, and my board chair, Cliff, is going to talk about, is what we're doing next to sort of mobilize our community around that idea. Cliff?
I'm going to talk a little bit about what our foundation goals are the next few years and follow up on Greg's start of the last 125. But first, I wanted to make a couple comments about this forum. Like many of you, I was here 5 years ago. The dialogue was similar. The discussion is very robust. And there have been great advances in that 5-year period in child health care. But not a lot happened after 5 years. However, I think that this year's forum is bringing a renewed focus to what we collectively have to do. I think Daniel Kraft said it yesterday pretty well in the morning when he said, we just aren't loud enough. There are a number of our foundation members here today representing Pittsburgh, and I think we've had some great take-home value that I plan to take back to Pittsburgh and share with the rest of our foundation. A couple examples. One statistic that I found particularly alarming was that a poor 4.5-year-old kid can be 18 months behind developmentally. I just found that really disturbing. Jane Wales said, let's make all 5-year-olds kindergarten ready. I think that's a great goal to have. Mark Shriver challenged us to create a national PAC. At least I think that's what he was doing. And I think that can become a reality. I'd like to take up that challenge and work with some folks here to try to create that national PAC so that we have a stronger voice on the Hill and in cities like Harrisburg, Pennsylvania. So Greg talked about the last 125. The next phase of our journey for our foundation, we assigned a task force, as Greg mentioned, last December to explore holding a children's health-focused symposium in Pittsburgh. The vision is to utilize the community resources that we have to spearhead an effort that could dramatically impact children's health and well-being in our region, and that region's western central Pennsylvania, eastern Ohio, and the panhandle of West Virginia. What we're asking, what would it take to make our children the healthiest in our region? What resources do we need to have that happen? What advances in pediatric research are going to be required? And what best practices need to be developed and implemented? How much money do we need to raise to have it done? We hope the conference will bring together a number of stakeholders, other nonprofits, local governments, county, city, state, academic institutions, healthcare and insurance partners, foundations, philanthropists, and of course our business community. No single organization can handle or resolve the complex challenges that face our kids or go beyond the battles that every hospital in this room faces every day, like cancer, diabetes, and rare diseases. In our community, that we face a lot of socioeconomic issues. Obesity rates in Western Pennsylvania remain alarmingly high. Substance abuse among teens and adults has become a tragic epidemic in our area. Every day, there are multiple overdoses that affect and devastate families and communities. In fact, one of the most highly visible drug traffic corridors runs from Youngstown, Ohio to Newcastle, Pennsylvania. Can we stop it? I doubt it. Can we raise awareness? I'm sure we can. 10% of young women report being intentionally physically hurt by someone they were dating. And of course, we have a lot of those 4.5-year-olds that hopefully will get to kindergarten or become kindergarten ready. The Pittsburgh City Schools has a 68% graduation rate, and we have 22% of our young population suffering from asthma. So our foundation goals support that of Children's Hospital. They did a strategic plan the last year and a half, and very simply they stated, over the next 10 years, we must make our children, adolescents, and young adults the healthiest in the world. So it's certainly been great being part of the Aspen Institute this year. I got a lot of value out of it. Thank you, Jane.
Thank you so much, Paul. And now I'm going to ask Ted Gerard to come up on the stage along with Dr. Michael Apte. Mike is president and CEO of the Hospital for Sick Children in Toronto, and of course Ted leads the foundation. So Ted also leads Woodmark Group, I should note.
Good morning, everybody. It's wonderful to be here, and it's wonderful to see so much energy around the topic of children's health. It's been really inspiring seeing what many of you are doing in your own environments. What I thought I would do this morning is to tell you a little bit about the way we're thinking about bridging fragmentation in our healthcare system as a way to provide a more holistic approach to children's healthcare. And specifically, I'm going to tell you about one example where philanthropy has been a real catalyst in driving different ways for us to think about the fragmentation and bridging that fragmentation in our system. First, let me just tell you a couple of things about the Canadian healthcare system. It really, first of all, isn't one system, but rather 14. Each province has an autonomous health system, and there's a 14th that addresses the Indigenous communities that's run by the federal government. It is a single-payer system within each of the provinces, but each province has defined its own way of organizing the system and the relative control that government exerts over the individual healthcare providing institutions. In Ontario, where we're located, is probably the most similar to the US in that there's autonomous self-perpetuating hospital boards. Hospitals and other provider organizations define and execute their own strategy, and they engage in a negotiated agreement with the government around what kind of revenues we'll receive for what kinds of services. Despite the similarities, there's one area that is pretty different. And the system in Ontario has a very high degree of fragmentation that's reminiscent to me of the US system in the late 80s, early 90s, before we started seeing the wave of integration that has been pretty much characteristic across the US. We have independent fee-for-service physicians, very few of which are employed by hospitals, although at the Hospital for Sick Children, we're a bit of an exception. Care delivery responsibilities are distributed across many different entities, each of which have a fairly narrow purpose, and that narrow purpose is reinforced by fairly narrowly defined service agreements with government to provide a certain bundle of services for a certain envelope of funding. Although there's no real barriers to the kind of integration we've seen in the US, it just hasn't happened. We haven't seen the kind of horizontal integration to build scale and try to achieve some scale economies. And we also haven't seen the kind of vertical integration that we've seen in much of the US to add value and to be able to deliver services in more complex, more accountable ways across a broader continuum. There's also fragmentation that I think is not so dissimilar in the US. And that's in the mental models that different stakeholder groups use to organize their thinking about the biological basis or the basis of disease, and to understand the contributors and the potential interventions that might have an impact on outcomes, even when there's broad agreement about what those important outcomes are. And I'd say that the most apparent area where this schism or fragmentation exists is in the world of children's mental health. And in the traditional sort of healthcare part of society that we'd be pretty comfortable in, hospitals, physicians, and those kind of organizations, we rely most heavily on what I would call a biomedical model disease. It's a very mechanical Newtonian model where there's a machine, there's some break in the machine, and then you get a bad outcome as a result of that break in the machine, a chemical imbalance, genetic deletion, or something like that. And we leverage the tools of inpatient care to control the environment, medications, complex technology to be able to look into brains and bodies and understand mechanisms of disease. Outside of the hospital, though, or that part of the healthcare world, there's a different model, and that is a model that is held tightly by non-medical providers, like often psychologists, social workers, and people that are more rooted in the social care system. And there, it's much more of a psychosocial model of disease where injury and coping is driven by the social interactions and the social environment in which children and families find themselves. And those social interactions in many cases are sort of overwhelmingly driven by concepts around parenting, peer interactions, and things like that. What that's created in our environment, and I don't think it's much different in the US, is a bit of that fragmentation has driven a bit of wariness, or in some cases even antipathy, and certainly competition for resources, attention, and the minds of donors, government, parents, and others in the community. And the reality is that the science is pretty clear that fragmentation, that schism, that difference in mental models is completely artificial. What we now know is that social interactions and the environment, including adverse childhood events, drive biology, and that biology drives our behavior. And to address the best outcomes, we now know we have to bridge the biomedical and psychosocial models of disease and think about the intersection between biology, social determinants, and mental state. And to create that bridge, we need to transcend the fragmentation that we see in our healthcare delivery system. We've done that in two ways. The first is to identify like-minded providers and join forces. In February, we integrated the largest mental health provider of services to children and youth in Ontario, an organization called the Hinks-Delcrest Center, that is squarely rooted in that psychosocial model of disease. Their staff are psychologists, social workers, and they are deeply embedded in the social care system. In fact, they're funded by the part of the government that funds the social care system. In June, we created an alliance between the two other freestanding children's hospitals in the province, something that's called the Kids Health Alliance, to try to create a more holistic and integrated way of bridging acute and post-acute care, and to think about the continuum of services for children with developmental disorders, autism, and other sorts of needs. The purpose of that alliance is not only to do work together, but also to provide a common operating system or a common framework for other organizations to connect with us. The other approach that we've taken is to rely on philanthropy as a catalyst to bring organizations together. And in 2014, we received an opportunity to have a $60 million pot of money created by a philanthropist, an anonymous philanthropist in town, that wanted to drive change in the healthcare system by forcing a consortium to come together of organizations that were involved in the mental health care space. And so we created a consortium of the Hospital for Sick Children, the Center of Addiction and Mental Health, which is the large mental health academic organization in the province, a community healthcare system, and the University of Toronto, which is the common academic partner of ours, to have a co-governed approach to create integrated approaches to care, an approach to capacity building that would extend far into the province, as well as a set of educational programs that were intended to build sustainable capacity and to change the mental mindset of caregivers to bridge that biomedical and psychosocial model of disease. It's been an incredible catalyst for forcing organizations to work together in ways that we probably would not have ever come to. It's also been a way to draw and leverage the government to provide and commit additional resources to top up what this philanthropist was willing to commit and contribute. And it's a great example of where somebody with a different vision for the healthcare system caused those that were actually deeply entrenched in providing the services to come together in new ways that has been a model for other philanthropists in our community. And I think Ted Gerard will speak about other examples where philanthropists have driven change. And I think it's also a good example of the power of bridging these different mental models of the way kids experience adverse childhood events, social stressors, and how that influences their psychosocial and mental well-being. Thank you.
So I have a minute left, and in that minute, I'm going to say that I came away from the last Aspen Children's Forum with really 3 core learnings. Number one, we have to do a better job of collaborating in our communities across different health organizations, as Mike has described, and with philanthropists to solve children's health issues, but more broadly other issues of children's health. And while Mike talked about the Medical Psychiatry Alliances, one example where we've partnered, I could give you many, many others where we are working with other organizations and philanthropists to solve system-wide problems. The second thing I came away with was the need to be able to use the legitimacy and I would say the passion that our communities have for our children's hospitals to tell the story about the needs of children. And so one of the things that has led to is actually the creation of a new organization in Canada owned by the 13 Children's Hospital Foundations, where we will use our collective voice across all 13 children's hospitals to tell the story about the needs of children and to activate philanthropic opportunities across all 13, as opposed to donors having to deal with just one. So that's another area that we've moved on. And the final one I will say is I came away with the understanding that we needed to change the narrative about how we talk about children's health. And we did that at Sick Kids last year. I could spend a whole session telling you how we've rebranded ourselves. But we wanted to move from a charity brand to a performance brand, from telling the community that we're just keeping up to we're winning and we need your support. And from help us to join us. Join us in this fight for children. The Versus campaign, Sick Kids Versus campaign, has become, I would say, the most watched charity campaign in Canada. Just last week, it picked up 8 awards at the Cannes Film Festival for outstanding marketing. But what it has done in our community, and actually our country and around the world, is it has changed people's perception about the needs of children. And I think coming out of this session, we will also find a way in which we can use voice and we can tell a story that perhaps is different than what we've done in the past. Thank you.
Thank you, Ted. Actually, just sit there. So, Rebecca, come on up. Is this on? Let me use mine. So, yesterday we heard a great deal about the link between poverty and health, and the need for proper nutrition, the need for interaction with a trusted caregiver, the need for self-housing, safe housing, the need to avoid toxic stress, and the impacts of all those things, if they're lacking, on health outcomes over time. And Rebecca, you only just were able to join us for the day today. But we also heard about, not only we're hearing today about the role the pediatric children's hospitals can play and are playing, but also the role of some really outstanding nonprofits, the catalytic role that can be played by philanthropy and the nonprofits they support. There was a missing piece, and that's the world of social enterprise. And so we wanted to have Rebecca Ani talk a little bit about this, about Health Leads, which she founded. So I guess I'm going to start, Rebecca, by saying, when you were a sophomore at Harvard, you had a big idea. What was that big idea?
Well, first of all, thank you for inviting me. I'd actually almost back up. We were talking before about Dr. Jack Geiger, who I'm sure a number of folks in the room know, and I think in many ways the story actually begins with him. So,
let's have Erwin listen up. We're talking about Jack.
This is a story you know well. So in 1965, Dr. Jack Geiger founded one of the first 2 community health centers in the United States in a desperately poor area of Mississippi called Mound Bayou. And so many of his patients came in presenting with malnutrition that he began prescribing food for his patients. And he would write prescriptions for fruits and vegetables and for milk and meat, and the patients would take those prescriptions to the local supermarket, which would fill them and then actually charge the pharmacy budget of the clinic. And as Dr. Geiger loves to share, when the Office of Economic Opportunity in Washington, D.C., which was funding Geiger's work, found out about this, they were livid and sent down a bureaucrat to set Dr. Geiger straight. Telling him that they had intended their dollars to be used for medical care. And of course, he goes on to, famously tell them that the last time he checked his textbooks, the specific therapy for malnutrition was food. So we laugh about this, and it does, seem absurd. He himself kind of loves to tell this story. But, Jane, to your question, in 1995, as a college student, I walked into the hallways of Boston City Hospital, and in particular the pediatrics department, and spent about 6 months talking with physicians and nurses and essentially asking them, if you had unlimited resources, what's the one thing you would give your patients? And heard the same story again and again, where they would say, every day we have patients that come into the clinic and the child has an ear infection and we prescribe antibiotics, but we know that the real issue is that there's no food at home. And we don't ask about those issues because there's nothing we can do. We have 13 minutes with each patient. Patients are piling up in the clinic waiting room. There's just a note for you here. Patients are piling up in the clinic waiting room. We weren't trained to deal with this stuff in med school. And we have a few social workers, but 24,000 pediatric patients who are either uninsured or on Medicaid. And so, Health Leads was really born of these conversations, and honestly, the question of what had happened in those intervening 30 years. And so our work began as a very simple model where patients could come into the clinic, they get screened for unmet social needs, food, housing, can they pay their electrical bills, like any other clinical vital sign. Physicians can then prescribe those resources to their patients, and then Health Leads work was around navigating patients to the existing landscape of community resources, and then critically actually closing the loop with the clinical provider so that they can make a better informed set of clinical decisions, right? So if your patient is homeless, maybe you don't do the 14-day course of antibiotics, maybe you do a 7-day course of antibiotics because they're more likely to be able to actually follow that medication regimen.
So in this process, are you gathering an awful lot of data on the sort of public health needs?
We are gathering an awful lot of data. I think, one of the most kind of profound realizations has been the degree to which candidly, unmet social needs have been described as a black box. And, at the level of a physician, we've heard this thousands of times across the country where doctors will say, when it comes to our patients' social needs, we practice a don't ask, don't tell policy. Candidly, we heard the exact same thing from health systems leaders across the country. They will say, patients' psychosocial needs are a black box to us. So, they may have, and, now all institutions have done community health needs assessments. But if you were to ask the CEO of a hospital, what % of the patients that came into your hospital in the past year are running out of food at the end of the month? we haven't yet met a CEO who can answer that question. And so this is about the opportunity to really engage in systematic data collection. And what's so profound is that it tells us really unanticipated things. So, one of the really interesting pieces of this equation is in one of our clinical sites, we found that 40% of the patients who screen positive for unmet social needs, meaning they have, serious issues with food or housing, paying their heating bills in the winter, 40% of those patients actually have commercial insurance. And I think it really broadens our notion of what poverty, childhood poverty, really looks like in this country.
So so the prescription is written. They then come to you've got student volunteers who are playing the kind of case management role.
Yeah, in the mid-90s, the model that we implemented was one that rigorously trained up college student advocates to, both complete a more extensive intake with families about what were the real unmet needs that they have, but then, to your point, to actually navigate them to the resources that they need to be healthy. So, help them manage language barriers and transportation barriers, bureaucratic barriers, barriers around documenting their income. And, to be candid, Health Eats work was always about a vision of a healthcare system that addresses all patients' basic resource needs as a standard part of quality care. But in the mid-90s, there were not care managers and case managers and promotores and African-American health conductors and patient navigators. And so, for us, the college student advocates were both an alternative workforce, but candidly also a way to really think about creating next-generation leadership in the healthcare system that had a profound understanding of the intersection of health and poverty. What's so profound right now is that, because these alternative workforces are now so prevalent through our healthcare system, Health Eats work is really now about arming all of these workforces and these healthcare institutions with the tools that they need in order to be able to address patients' social needs in a systematic, data-driven, high-quality way, and to really allow healthcare institutions to have a much more profound understanding of not just the realities of the patients' lives and what will be necessary for those patients to achieve health, but also the strengths and gaps in the resource landscape. Just one quick data point on this. What our data shows across geographies, Health Eats works across the country, literally coast to coast. What we have found is that 1% of the resources in any given community, so 1% of the job training programs, the food pantries, the Head Start programs, 1% of the resources drive 51% of the successful resource connections we make for patients. 10% of the resources in communities, the government programs, the nonprofit organizations, 10% of those resources drive 90% of the successful resource connections for patients. So this really allows healthcare delivery organizations like children's hospitals, and we work with a number of them, to really be able to really identify which are the entities in the communities that are really driving results for patients and be able to build enduring relationships and partnerships with those community-based organizations.
Now, your goal at one point was to scale in the sense of replicating this model in multiple clinics, et cetera, across the country. But first, before I ask you how your goal may have shifted, I wanted to know what kind of feedback are you getting from the ultimate beneficiaries of this, the patient, the child, or the family? And I'll move to another point of feedback, but let's start with the beneficiary.
Yeah, I mean, here's the bottom line is that, patients and, in the case of pediatric patients, their parents, they know what their kids need to be healthy. We just haven't even begun, really, to design a healthcare system that accounts for that reality, right? That invites that conversation as part of each doctor's visit. And so, what we find is that in the clinical context where we actually have set up structures and clinical pathways and have the right workforces in place, there's an incredible sense of relief on the part of patients and their parents to be able to talk honestly about what they know their children need to be healthy. We know that only 10% of health outcomes are actually tied to clinical care. 70% of health outcomes are tied to social and environmental factors, and parents know that. We had this one case that I think is worth sharing. We work with a large academic medical center in Baltimore. And there was an adolescent patient who came in, losing weight. And the doctors were incredibly frustrated, trying to figure out what was going on, and they were sort of huddled up trying to figure out which blood tests and which metabolic panels to run. And one of our Health Leads trained advocates was standing nearby and said, "Do you think the patient could be hungry?" And honestly, the doc was kind of incredulous. He was like, he didn't say anything about being hungry. But in fact, of course, this kid had been kicked out of his housing a few weeks earlier and just literally hadn't been eating. And he said he was so relieved that someone finally asked him. And I think, when you think about kind of how we think about our healthcare system, we're often asked, what's the return on investment in asking patients whether they're hungry? And, we would really ask, what's the cost of the healthcare system of ordering metabolic panels when the real issue is that the patient's hungry?
Yeah. And of course, what we've been hearing over the past few days is the extraordinary change in the direction that you're talking about in each hospital. But there is always the issue of cost, what pays for it. This volunteer approach, I assume, has vastly reduce the cost. And since you're connecting people or patients to existing services that they're not connected to, this isn't a more expensive model, is it?
Well, no, and I actually think the real opportunity here is in some ways less about whether it's a volunteer workforce or it's a paid workforce. And actually, I would say Health Leads now mostly works with healthcare institutions that have paid workforces. The real question is, what are we choosing to pay for in our healthcare system? And I actually think this is an arena where philanthropy has a uniquely catalytic role to play right now. There is, I can speak as a quick example about North Carolina. So, North Carolina, as folks know, has a very divisive political context right now. There was just a long article about it in the New York Times. I'm sure many people saw. There's a Democratic governor, a Republican General Assembly, but North Carolina made the decision that they were going to shift all of their Medicaid, and that includes 1.1 million children who are on Medicaid, shift all of their Medicaid to managed care by 2018. And what has been so profound about that shift is that it has brought together this really kind of unconventional, unusual set of suspects around really grappling with what is going to be required for health in our patient population. So the Medical Society, which is the docs, the Hospital Association, commercial insurers, community-based organizations, healthcare delivery systems. And what is so powerful in North Carolina is the opportunity for philanthropy, not to be underwriting necessarily the replication of programs community by community, but actually providing some of the capital that's required to bring together these unusual suspects to really change fundamentally what's paid for, so that it's less about kind of which workforce and much more, are we actually spending our healthcare dollars on health, or are we limiting those to the sole problem of managing disease?
So let me ask you sort of what now? You've got your plan for growth and scale was to add more desks to various clinics. What has been the response of your partners about your next steps?
Yeah, so we, Health Leads kind of, really for almost, 18 years, really put our head down, kind of hammering away at how do you operationalize integration of social needs into care delivery? What are the clinical workflows? What are the fields in the electronic health record? Who's asking the questions of patients? What's the data we collect? And what I would say is that, we had incredible success doing that and great results. And so, the notion was, well, we would replicate, right? We had 20 of these implementations in 6 geographies, and we spent a ton of resources, creating a strategic plan that was going from 20 desks to 80 desks. And the idea was that we were going to raise $33 million in unrestricted philanthropic capital to enable this. We had raised $20 million of it. And we had this really profound moment where we sat down with health systems leaders and they said, I don't want another Health Leads desk. I'll never forget talking with the CMO of Health and Hospitals in New York, where Health Leads had been, implementing our model for a long time at that point, saying, I have 1.5 million patients on Medicaid. How do we make addressing social needs part of every visit for every patient every time? And so it was this incredibly liberating opportunity to say, this is not about replicating Health Leads' model, however good it is. This is about shifting the culture and really the mental model of what counts as healthcare in this country. And we were able to actually go back to those donors, and we ended up raising $35 million, and saying, Health Leads, we could replicate infinitely, and it would never matter. right? It was really hard to say that to ourselves. We're so proud. We had had exponential growth, incredible results. But meanwhile, 1 in 5 Americans gets care through Medicaid, and we're celebrating the growth from 4,000 patients to 10,000 patients to 80,000 patients. But those numbers don't matter. We don't have the time for that kind of incrementalism. And so, we really went back and took a hard look and said, we're just, this is a different endeavor now. So we're going to do 3 things. One is we're going to work with a small number of institutions to actually prove up that you can address social needs as a standard part of quality care, not just in a clinic, not just with your asthmatic patients, but across an entire institution. And so we're working with a set of health systems, Kaiser, Rainbow Babies and Children, and a number of institutions to really tackle that endeavor. There's not a single healthcare institution in this country that yet does that. The second piece was to say, basically over a 2-year period between 2012 and 2014, we had 1,200 inbound expansion requests from health systems across the country. And, Jane, to your point, part of what we realized is the conversation around social needs, social determinants of health is starting to change. And we set up a whole slew of learning collaboratives to arm health systems across the country with the tools that they need in order to do this work well. The screening tools, workflows, technology platform, data and analytics. And then the third piece, which is critical, is really engaging seriously around the ecosystem. And notably, one of the key pieces of this was that in 2016, the Centers for Medicare and Medicaid Services, right, the largest purchaser of healthcare in the world, $957 billion a year. In 2016, all those years after Dr. Geiger had his insight, for the first time launched 2 pilot initiatives that recognize social needs as part of what counts as healthcare, literally for the first time. And one is the Accountable Health Communities pilot, one is what's called the Comprehensive Primary Care Plus pilot. And AHC, Accountable Health Communities, was actually modeled on Health Leads. We were integral in some of the design work around the Comprehensive Primary Care Plus pilot. In 2016, probably hundreds of thousands of patients in this country were screened for social needs. When these 2 pilots began to go live in 2017, and they've both launched post-election, they're anticipated to screen 10 million patients a year for unmet social needs. And that's the kind of exponential impact that we're really seeking.
So, Rebecca, thank you for joining us for this. Let me just say that since Rebecca started on this journey, she's been awarded the MacArthur Fellowship, also known as the Genius Award, and she's given a TED Talk, so you get to hear more by listening to the TED Talk. But we're all about the whole concept of how culture has changed, and you look like you're doing it. So, Rebecca, thank you so much.
Thank you.
So, next time some college sophomore comes to you and says, gee, I need a mentor, go for it, the way Jack Geiger did. Now, we're going to have a chance now to break into the table talks, but I thought Cliff kind of created an opening for you, Mark, to maybe say a word about what's happening in Washington today and what we should do about it. So I'm going to ask Mark Wojtek just to come up for a couple seconds, if you don't mind. I thought... I couldn't resist Cliff's invitation to you, in essence.
Okay, thank you. I'm back again. This meeting, when we scheduled it, we didn't anticipate that we would have a live bill in the U.S. Congress with a fairly monumental impact on kids funding. So at the risk of just being U.S.-centric for a couple of minutes, I wanted to give you just a brief update on where that sits. We've got the Better Care Reconciliation Act, or the BCRA, which is has in it a Medicaid reform. And what we'd like to do is to ask those of you from an advocacy standpoint who know a U.S. senator to be in touch with them, and you should have a couple of basic messages. Number one, this is a $40 billion cut in the healthcare budget for 30 million U.S. kids on Medicaid. That's really a very factual, high-impact statement. And while Medicaid's a good program in a lot of dimensions, we didn't like the baseline before we started this. These kids have become collateral damage in the path of the legislation. And it turned out that this revised bill was dropped yesterday in the middle of this. So we had our 15 U.S. CEOs who are here, and we went through a brief debriefing this morning on this, and they thought it would be helpful to enlist your support as you may. I would say if you have Democratic senators, don't take the point of view that, well, they're already opposed and we know they're sympathetic. We need the voices for kids spoken on the floor of the Senate this week and next week. This bill could be actually enacted in the next week and a half, and it would be a terrible setback for kids. So we don't want to make this a political meeting, but we do have lots of U.S. attendees here. I will make one Canadian comment, which Katie and Mike and others will enjoy. We had our 15 U.S. CEOs gathered over there this morning at 7:30, and we're going through these tens of billions of dollars of cuts, and we see Mike out there in the sunshine having coffee, and everyone looked over and said, we want to be him. Anyway, thanks for your attention on that. If you have any questions about that, ask me directly or any of your CEOs who are here. They're all been debriefed, and we appreciate your help. Thank you.
And for those who are maybe not comfortable with lobbying, let me just say, calling your own member of Congress is not lobbying. It's a citizen obligation. Calling somebody else's member of Congress is lobbying, and you're allowed to do a little of that, too. So what we're going to do now is take a very quick break, if you don't mind, and get back here at 9:45 so that you can join one another in table talks. We have one request of you in this. The philanthropists in the room, do your best to sit with folks you don't know. Because the notion is to find out where you can see eye to eye. And so, don't sit with your best friend or your spouse, but join tables with folks you don't know as well. Thanks so much. Take a quick break.